Hey everyone, and welcome to tonight's webinar. I'm Jemima Mead, Head of Marketing at VET.CT, and in a moment I'll introduce tonight's fantastic speaker. Before that, and just while we wait for everyone to join us, I'm going to take a moment just to talk you through a little bit about VET.CT and how our radiology service can help you, your teams, and your patients. So VET.CT, if you don't know, is a global company of over 150 radiologists, and we are here to help you. Not only do we annotate images, we will help you whether you are in first opinion practice, university, specialist hospital, or another clinical setting. Our team of radiologists provide expert interpretations on a range of imaging modalities, from X-ray through to CT and MRI, fluoroscopy, nuclear medicine, and across the full spectrum of species. What sets our team apart and the service that we deliver apart is the quality of our reports that our exceptional radiologists provide. Not only do they annotate the images that you see, so that you see the areas of concern that our teams see, we ensure that the reports you receive contain clinically relevant differentials and comments that are relevant to the history that you provide us, and all of our reports are backed by our unique clinical warranty. What that means is that you can trust the information in them and proceed with the next steps for your patients with confidence. Not only that, but we have an incredible support team who are all clinically trained and are available 24/7. You can ask them for help and support at any time. You can also communicate directly with our team of radiologists if you have any questions about your case. Would you mind advancing, please, Olga? If you'd like to see the VET.CT difference for yourself, you can scan that QR code and see an example of some of our reports. You can also reach out to our client success team at that email address for a no obligation phone call. Simply give us an email and we'll arrange time to talk to you and show you a bit more about the company and the service that we can provide. Next one. So just a tiny bit of housekeeping about tonight's webinar. It's being recorded, and what that means is we'll share the link with you afterwards, either so that you can rewatch it or share it with colleagues. The talk will be about 30 minutes long. We'll then go into a Q&A session. So if you would like to submit any questions, either as they come up during the talk or at the very end, please do so using the comment box, which you should find at the bottom of your screen. Next slide, please. So on to tonight's webinar. It's with great pleasure that I can introduce Olga Travetti to you. Olga did her residency in diagnostic imaging in Ghent, Belgium, and she became an ECVDI diplomat in 2014. She's worked in both private practice and in academia. We're honoured the fact that Olga's worked with us as a radiology consultant since 2018. So with regards to tonight's webinar, it's probably no surprise for those of you who are on the call that CT in cats and dogs is rapidly growing. Our team get asked for help in a lot of different situations, including improving image quality and diagnostic accuracy, and discussions about when CT is best used. Olga's talk tonight is a discussion of clinical cases where you might want to consider CT. We really hope you'll enjoy it. Over to you, Olga.
Thank you, Jemima. So I will repeat quickly this introduction to the webinar, although the majority of you that follow the previous webinars already know about this. So we are essentially trying to cover the concept that were discussed during the technical lectures to illustrate the key advantages of this modality CT. So we are trying to address the common questions such as why should I choose CT, what kind of information, and when is it actually indicated, and how can it influence my patient. So this was a series of 4 sessions. This is the 3rd one, and I will also host the 4th and last one next week. In each session, as Jemima said, we have 3 cases which has been selected, and they will be discussed over 30 minutes. So it's approximately 10 minutes per case. And then we have a Q&A at the end. So these cases illustrate the strengths of CT, and you're really welcome to ask any question you may have. The learning objective for this webinar is to demonstrate the key strengths of CT, which we think is a fantastic imaging modality, and to differentiate this modality from the others to see what are the pros and the cons and when one is indicated compared to the other. but also to explore how having a CT report can actually change quite a lot the outcome of your patient and the care you can provide to the patient. Okay, without any further ado, let's start. This is my first case, which is case number 7, and it's a German pincher. It's a male dog, 4 years old, who presented with the acute onset of a 3 out of 5 right thoracic lameness, with pain clearly localized to the region of the right shoulder. So the referring vet sent us some radiographs. These are very high quality radiographs. We have a mediolateral and microcaudal. They are pretty much unremarkable. We have essentially an unremarkable radiographic exam with a dog that presented with a clear localized pain in the right region of the right shoulder. So it's something that cannot be ignored, and the idea is to have more imaging. What we want in a situation like this, when we have a patient with an acute presentation, clear source of pain, but no changes at the radiographic exam, we want a modality that has even better bone detail, but can also offer some soft tissue definition. And we also want something that can show not only the region of the pain, the shoulder, but also the anatomy around that region. Because in our patients, we can, of course, localize the pain, but we can never be completely sure because they cannot say exactly where the pain is. So it's good to have a modality that shows you quite a lot of anatomy. So the clients decided to perform a CT, and now I am presenting with you the CT of this patient. We have on the left-hand side a bone algorithm, and in the center and right side we have a soft tissue algorithm, pre-contrast. But on the right side I have a parasagittal right MPR reconstruction. So I'm going to start show you. So we are going toward the region of the scapula. So you can look on the left side. The scapula looks normal. I don't have any periosteal bone or any change. And here I am at the level of the joint, and you can see there is a very, very small focal mineralization at the level of the caudal glenoid, which is probably a separate ossification center of the glenoid. Then you can look at the center where we have the pre-contrast. You can see, first of all, there is a little bit of effacement of the subcutaneous fat. So you can see the region of the subcutaneous fat is a little bit effaced, and I put some asterisks to show you that. And also, if you look in this region, this is the infraspinatus muscle, is hypoattenuating compared to the other muscles that I can see in the anatomy of the dog here. And here I have gone to the parasagittal right, and I have actually measured the attenuation of the muscle in Hounsfield units, which is the unit of density in CT. And you can see that the infraspinatus is only 35, and the supraspinatus, which is normal, is 51. So the impression is confirmed, and we essentially have a muscle that is diffusely hypoattenuating compared to the other muscles in the body. So I was very pleased to see that in this case, the client decided to inject the contrast in this patient. And before starting the video, I want you to pay attention to this triangular structure. This is the deltoid, the scapular portion of the deltoid muscle, and it lies immediately superficial to the infraspinatus muscle, which is indicated by the red arrows and red ellipse. And this muscle has a normal attenuation and contrast uptake. So this is something to take note because it's an important detail. And now I want to show you just the contrast uptake of the infraspinatus muscle, which is really heterogeneous with these linear areas of contrast uptake and almost cavitary regions in some aspects. And this abnormality involves the whole muscle from its origin to its insertion. This is just a schematic representation of what I just told you. So on the left-hand side here, you have the infraspinatus muscle, and on the right-hand side, you have the scapular portion of the deltoid that lies superficial to the infraspinatus. So this is an important detail because if the dog has sustained a trauma from the outside, it is very likely that the scapular portion of the deltoid would have been abnormal And instead it was normal, as we saw, because it had a normal volume and a normal contrast uptake. So summarizing what this CT shown us is that this dog has a diffuse right infraspinatus myopathy and also some edema or cellulitis of the subcutaneous fat immediately adjacent to the muscle, and also a couple of incidental findings that are not related to the cause of the lameness. So infraspinatus myopathy is a well-known entity and it is not fully understood in terms of etiology. In this case, we know for sure from the CT that this is an acute myopathy because the muscle was thickened, hypoattenuating in pre-contrast with an abnormal contrast uptake. So this is an indication that the problem was acute. And because the muscle was diffusely involved and there was no changes in the muscle, in the deltoid immediately superficial to it, it is more likely that maybe it was a vascular or hematogenous infection, a vascular disease or a hematogenous infectious, although we don't know for sure. We haven't seen any foreign body, although we cannot completely exclude it. It's quite unlikely because the muscle, again, was diffusely involved. So what did it mean for this patient? We have confirmed the clinical localization and we have specified the origin of the pain. And we also specified that the condition is diffuse and not focal, which is an important detail. We have some differentials for the nature of the condition, although we cannot specify for sure. And of course, we have excluded other significant causes of right thoracic lameness, which is important. For example, we have excluded tumors and DJD. So how did it impact the patient? We have a diagnosis, infraspinatus myopathy, and we can start thinking about the next steps. For example, some colleagues may decide to biopsy the muscle. Also, we can give the owners an expectation for future complications because this condition is unfortunately associated with a risk of future contracture of the muscle. So this is something to be aware of. And now we have to think, could we have achieved the same result with a different approach? So we could have used ultrasound. Ultrasound would have picked up the thickening and the abnormal contrast uptake of the muscle. But doing musculoskeletal ultrasound is not very easy. So we need to have staff trained in musculoskeletal ultrasound to do them. And in this specific case, because the whole muscle was involved, it would have demanded an extensive clipping of the patient. So this could be not ideal in certain climates or with certain type of owners that don't really want to have the dog completely clipped. But otherwise, it would have been okay. So there are many papers talking about this condition, so I have mentioned just a few. And then at the end of each case, I usually want to give you some key points, but in this case, I want to look at the next case with you first, because the two are connected. So we will do the key points all together. Okay, so moving to the next case, this is another orthopedic case, and we have a border collie, a 6-year-old, and he has an acute onset of left pelvic limb lameness that occurred during agility. And there is pain on the hyperextension of the left stifle. However, that could be the hip, it's not very clear. So the referring vet took radiographs. So we have the ventrodorsal of the hip and we have a craniocaudal of the stifle and tarsi, but we do not have mediolateral views of the stifles. So starting from the hip, well, look pretty normal. I don't see a sign of hip dysplasia or degenerative joint disease. And instead, for the craniocaudal of the stifles, I have the impression something is going on with my lateral fabella. But it's not really clear because unfortunately they are at the edge of the field of view, and also they are a little bit underexposed, and also the stifles are not very straight in this case. So the result of this radiographic exam, essentially, we know that the coxofemoral joints are unremarkable. There are no fractures, no aggressive bone lesions, but we are a little bit limited because the technical quality of these radiographs wasn't perfect. And in this case, also, we have a CT. So here I'm showing you on the left-hand side a transverse image of the left stifle, and on the right-hand side in bone algorithm, a sagittal reconstruction of the stifle, and I've put an asterisk at the level of the infrapatellar fat pad to show you that there is no joint effusion, which is something that we can clearly see from here. So now we are going towards the stifle joint, and we can see immediately that the lateral fabella is sclerotic, and there is a little osteophyte at this level, and also some smooth periosteal reaction along its margin. And also now we see a mineral focus in this muscle here. So this muscle is the lateral head of the gastrocnemius, and we can confirm it here in our parasagittal view on this side. So we have quite a few findings, and I was very pleased also in this case to see that we do have a post-contrast CT. So now you are looking at soft tissues, and you have in this case I've also put the right stifle because I think it's nice for comparison. So you have in the center your post-contrast left stifle, which is the lane 1. You have on the left-hand side a sagittal reconstruction of the post-contrast, and on the right-hand side you have a normal stifle, which is the dog's right stifle. Okay, so we can immediately see going down that we have an abnormal contrast uptake at the level of the lateral fabella, and the contrast uptake is extending within the musculotendinous junction of the lateral head of the gastrocnemius. And it's quite a vivid contrast uptake, definitely abnormal. And we also have here effacement of the adipose tissue that normally should be between the joint capsule and the muscle. If you look on the right-hand side, which is the right stifle, the normal one, you can see this nice hypotenuating area between the joint and the muscle. That's adipose tissue, and it's supposed to be there. So we don't have it anymore here, which is because the lateral head of the gastrocnemius is abnormal, is thickened, is swollen, and it has basically pushed away the fat. It was quite a prominent focal lesion of the lateral head of the gastrocnemius, and it is located here at the level of the junction between the tendon and the muscle, the musculotendinous junction. So, summarizing our CT findings, we have a mineral attenuating focus in the lateral head of the gastrocnemius, and we have a non-aggressive periosteal reaction at the level of the lateral fabella. But we also have a area of heterogeneous contrast uptake in the lateral head of the gastrocnemius near the proximal insertion, so at the musculotendinous junction, and it's a focal lesion in this case. And we have some effacement of the fascial fat at the caudal aspect of the stifle. So concluding, we have a gastrocnemius musculotendinopathy, which is another very well-known condition, and was described in Border Collie for the first time. But now we know it can affect any dog. So what did the CT tell us? First of all, confirmed the origin of the lameness, the left stifle, and also interestingly showed us that we have a chronic process. And we know that the process was chronic because we had the periosteal reaction of the lateral fabella, but also the mineral focus within the muscle. But now there has been an active inflammation. So something has happened acutely, and there is a focal recent lesion at the musculotendinous junction. So how did it impact the patient? First of all, we have the source and the mechanism of lameness, and we have outlined a chronic process that probably the owner wasn't aware of. So probably the dog was coping very well with the chronic musculotendinopathy that has now become acute. Could we have diagnosed it differently? Ultrasound in this case may have picked up the region of active inflammation in the muscle. I have to say this was a big dog, so it depends how much subcutaneous fat you have and how deep is the lesion in the muscle. But potentially, yes. Certainly, we would have been able to pick up the focus in the lateral head of the gastrocnemius if we had orthogonal X-ray views. And MRI would have been equally diagnostic, if not better than CT, but of course a little bit more expensive. So now we are essentially summarizing the key points for the last two cases. CT is actually an excellent modality to pick up soft tissue details in certain orthopedic conditions. So these include myopathy, myositis, areas of muscle necrosis that can happen, for example, for metastatic lesions, hemangiosarcomas, but also abscesses in muscles and foreign bodies. However, the outcome of CT may be less predictable if you have a chronic myopathy, because you can see some indirect signs on CT. For example, you can see that the muscle fibers are replaced with fat, you can see some muscle wastage, and you may or may not see an abnormal contrast-uptake, depends. And also in chronic tendinitis and tenosynovitis, there is a little bit less ability to detect the loss of tendon fibers with CT. So CT can be used in myopathies, very useful to distinguish between a primary and a neurogenic myopathy. For example, if you have a dog that has muscle wastage, has lost the volume in a muscle, with a CT you are able to pick up if there is a lesion to a peripheral nerve that innervates that muscle, and so you can diagnose a denervation or just a muscle atrophy because you have a chronic myopathy. CT is also very good if you want to plan a biopsy because you can see where the abnormal area are and basically enter with the needle exactly where that is to increase your chances of a conclusive result. And of course, it can help classify the disease according to the extent, the degree, chronicity, and so on. So it's an excellent modality also for musculotendinopathies, which is something we don't classically think about CT. We always think about bone detail. And here we have a couple of references on this very common, not very common, but quite common condition. Good, so I think we can move to the last case. So this is a completely different story. This dog, unfortunately, has been hit by a car recently and has incredible pain at the level of the hip and on the right side of the body, thorax and hip. And the veterinarians did a quick ultrasound and they saw an intact urinary bladder. I'm going a little bit quick with the radiographic changes here because the case is quite long, but you can clearly see there is definitely a fracture of the body of the ilium with a very sharp fragment directed toward the pelvic inlet, which is why they did a quick ultrasound, and a couple of incomplete fractures. So summarizing, we have fracture of the body of the ilium and a couple of non-displaced fractures at the level of the sciatic arch and the pecten of the right pubic bone. But in this case, interestingly, we have also thoracic radiographs. And so here we have quite a few changes, actually. We have a rounding of the costophrenic angles indicated with the green arrows, and a thick and a pleural fissure at the left side indicated by the yellow arrow. So these findings together mean that there is a little bit of pleural effusion. We also have this triangular areas of soft tissue opacity with the base directed toward the mediastinum and the apex directed toward the chest wall. They are indicated by the blue arrows. And those, they're called reverse fissure lines, and they are essentially indicating a mediastinal effusion, which is a little bit less common. You can see also this increased opacity superimposed to the heart. So we have mediastinal and pleural effusion. But when we look more in detail, there is more. So we have two areas of interstitial opacification, the right caudal and left cranial lung lobe. And then we have areas of gas opacity superimposed onto the fluid opacity in the pleural space. So we have fluid and gas at the same time within the pleural space, and that's called a hydropneumothorax. It's quite an uncommon condition. We don't see it a lot, and in this case it's very, very mild, but it is almost always traumatic. So this dog has quite a lot of problems. He has mediastinal effusion, hydropneumothorax, two regions of interstitial opacification, which in radiographs are really unspecific. And then we have some other incidental findings. So mostly because of the areas of interstitial opacification, and I assume because the dog was probably a bit dyspneic, they did a CT. And here I'm showing you a video. On the left-hand side, you have a soft tissue post-contrast, and on the right side, you have a bone, high resolution, but it's optimized for the lungs, let's say lung algorithm. So here with the green arrows, you can see the mediastinal effusion, which we know already is present. And now if you look on your right-hand side, you will see the areas of interstitial opacification that are quite visible, actually. You can see it, you can see it here at the level of this ellipse, and there is another one a little bit more cranial, and you see also the little bit of gas in the pleural space and a little bit of fluid in the pleural space. So far we have the same, essentially the same information that we had with the radiograph, but the interesting point was looking at the bone algorithm. I reconstructed on the right-hand side a dorsal plane, and you can immediately see that there are two displaced paravertebral rib fractures. These are the 8th and the 9th rib. And this is something that we didn't pick up previously. So when we look at the transverse slices, we can see that it's a really sharp fragment at the level of the fracture, and the fracture fragments are located exactly at the level of the pulmonary opacification. This is a bone window, but you can still see that the level of the pulmonary changes are at the same level of the displaced rib fractures. So this is quite an important finding that we had no idea before. So going back to the radiograph, this is obviously very much zoomed in, but I wanted to check if they were detectable on radiograph. And I would say that for the 8th rib, I can probably see in retrospect a double cortex, so an interruption of the cortex. So the 8th rib could have been suspected, but it is superimposed to the heart in the mediastinal effusion. So it wouldn't be something I would make a call. But then the 9th rib, definitely not, because the 9th rib looks simply slightly deformed, and that often happens when there is a chronic fracture and there is a bit of a bone callus. So I wouldn't have been able to definitely call the fractures from the radiographs, although in retrospect something is visible. There is more to this case. So the dog was very painful on the right-hand side, and reconstructing the right scapula, I just noticed this hairline fracture, which is at the level of the base of the spine of the scapula. And even when you scroll through the bone algorithm transverse, you can probably see it just very quickly, very subtle. So there is an incomplete fracture of the scapula that we knew nothing about, and radiographically this is impossible to detect with this view and with any view for the position it is, because it's incomplete. So this wouldn't have been diagnosed in any other way. And finally, I wanted to show you also the abdomen, because this is quite something that can happen, and I've seen previously in dogs that have really bad hip fractures. They bleed and they develop hematomas in the retroperitoneum or the peritoneal space. In this dog, you can see there is this area here, and this one here. These really light gray areas represent peritoneal effusion, very mild. And in the center, this hyperattenuating tube is actually the ureter, the right ureter, and it's visible here in the middle. So the right ureter is passing straight into this peritoneal effusion that is forming at the moment. And now when we look at the ureter going towards the bladder, sorry about this. So you can see that the ureter, which is indicated with the red arrows, is decreasing in diameter when it passes through the peritoneal effusion. This peritoneal effusion is probably some some degree of bleeding. And essentially, what can happen in some cases is that patient develop a ureteral entrapment. So ureteral entrapment is when you have a hematoma that is formed because of, in this case, pelvic fractures, and the ureter passes in the middle and gets compressed. So this is quite important because we need to know about this, and it's something that should be monitored. So CT basically gave us three very important new findings, which are the displaced paravertebral rib fractures and the incomplete fracture of the scapular spine, and also the ureteral narrowing, which could be a moment in peristalsis of the ureter. So in this case, I would have liked to have a delayed phase to see if the restriction continues or is just temporary. And if it was temporary, it was definitely only peristalsis, or if instead the ureter is actually entrapped, and in this case, we need to monitor. So we know also the cause of the pneumothorax, so probably the lungs have been injured when the dog breathed, because the rib fractures are really sharp. And it is also probably a good thing to not drain the pneumothorax at this stage, because it keeps the surface of the lung away from the very sharp rib fractures. And we have new abdominal findings that we didn't have before. It will impact the patient, first of all, for pain management, because of course now we know there is also a fracture on top of all the rest, and it definitely justifies the pain on the right side of the body, but also because the veterinarians will now monitor with ultrasound the size of the right kidney, and if they see any sign of hydronephrosis, then they know that actually we have a ureteral entrapment and they can act upon this. So as a result, this very complex trauma case is probably much easier to handle, and in response, the patient will receive a better overall care. CT is actually excellent in trauma cases, and it can detect really subtle conditions that radiology misses. In this case, the rib fractures, particularly the paravertebral rib fractures, are really difficult to see on X-ray, even when they are displaced. And could we have achieved the same with different modality? I think with ultrasound, we're just going to be able to monitor the ureteral entrapment, but usually ureters, when they're not distended, are very difficult to see on ultrasound. And X-ray will be useful for monitoring the pneumothorax, although as you probably have noticed, the pneumothorax on CT was very underwhelming compared to the amount we had on CT, and CT also told us that it was frankly unilateral. So final roundup, just to summarize what we have seen in these three cases. So we have seen that CT allows excellent detail of bone structure, and it can quickly characterize complex findings because of the lack of superimposition. But CT is also very good with focal and diffuse soft tissue lesions when intravenous contrast is administered. But of course, we need critical analysis of impact to understand what are the important findings compared to the ones that are not clinically relevant. So thank you for your attention. And I would be happy to take any questions if there are.
Thank you so much, Olga. That was brilliant. You've really brought to life some really good scenarios for CT. If you do have any questions, we've had a couple, but if you've got any more, please just pop them in the chat box below and I'll pick them up and ask them to Olga on your behalf. Olga, we've had a few come through. So the first one is it always recommended to inject intravenous contrast in orthopedic CT scans?
Yeah, it's a very good question. Actually, recently I have seen more and more clients that inject routinely contrast when they scan elbows. I have to say I am diagnosing more musculotendinopathies than before because of this, the addition of the contrast. I wouldn't necessarily say that a CT of the elbows, for example, is incomplete if we don't have the contrast. It is totally fine to send it without, but it definitely can add information. And I would add, if you work in a setup where you are not able to interpret the images as they are acquired, and you're unsure whether or not what you have just acquired justifies the clinical signs, in doubt, I would give the contrast, because that would increase the chance that we achieve a diagnosis.
Okay, makes complete sense. You mentioned there a musculotendinopathy. There is a question about musculotendinopathy, so I'll follow with that one then. What are the factors that I should consider when choosing between CT or MRI in a patient where I suspect a musculotendinopathy?
Another very good question. So in the two examples I gave, the lesion was, in one case, was diffusely through the muscle fiber, and in the other case was at the musculotendinous junction. So the muscle fibers are much more vascularized than the tendons. So when you have focal lesion in a muscle or at the musculotendinous junction, contrast CT is very likely to pick it up. So if you are pretty confident that your lesion is musculotendinal or muscular, for example, because you have a swelling or because you have pain in that region and is fairly acute, CT is absolutely fine. However, if you have a tendinopathy, for example, a bicep brachii tendinopathy, which is quite common in our patients, and you suspect that this is chronic, because the tendon fibers are not so vascularized, and also because the condition is chronic, CT may not pick up any abnormal contrast uptake. But it could pick up indirect signs of the chronic tendinopathy. For example, new bone formation at the level of the bicipital groove, but also some joint effusion around the biceps tendon and so on. So it could still be able to detect the indirect signs, but not pick up the lesion directly, as ultrasound does, but also MRI does.
Okay. Makes total sense. We've got a couple here about trauma and the role of CT. So the first one is, what is the role of CT in a trauma patient and when's it most useful?
Yeah, so trauma patients, it's a very stressful situation for the clinic, and I think CT is an excellent modality if you have the option. CT can be done under sedation. You don't have to administer general anesthesia if you can't, because the patient is not stable enough. And in case the patient cannot tolerate the contrast because he's hypovolemic, hemodynamically unstable, you do not have to, because most fractures and pneumothorax are detected without. And I think the thing that it makes it excellent in trauma, and this is hugely also documented in human beings, is the fact that it's very fast and you acquire a lot of information in only a few minutes. And if you were to have to get all of those information with X-rays, you would have to position and reposition the patient and change the position and the side of the patient many times. In a patient that is not very stable and painful, that's not ideal. So I think CT is widely used in trauma, and I think it's one of the most excellent uses of CT.
And then it leads on to a second question, which is, are there any other specific special considerations about using CT in trauma? For example, inability to get apnea. How does that affect image quality and making diagnoses in these kind of unstable patients?
Yeah, so if you are not able to have a controlled ventilation, I think this is what they refer to, it's absolutely fine. We'll have a bit of motion artifact, but motion artifact is not invalidating the study. It would be very difficult to interpret, for example, a shunt in the liver if we have a dog that is breathing during the study, because we are looking at tiny vascular lesions. But if you are talking about a trauma patient, most likely you are dealing with a pneumothorax, with a pleural effusion, with fractures, and those are fine even if we have motion artifact.
Okay, so still go with the CT as long as the patients go with the CT. Great.
Yes.
Final question, unless anyone else pops anything in, is how good is CT at detecting foreign bodies in soft tissues? We're often advised to use ultrasound to rule them out first.
Yeah, we do in our reports. The point is CT can detect foreign bodies that contain gas. For example, pieces of wood contain little bubbles of gas, and we can see those. We can see metal foreign bodies, and also we can see hard plastic on CT. But what we cannot see are vegetal foreign bodies that were embedded in soft tissues for a long time, because they absorb liquid and they become the same attenuation of the rest of the soft tissue, so we can't see them. And also very, very tiny foreign bodies, such as grass strands. In this case, ultrasound is actually more sensitive, because if you put a probe on a blade of grass, you can actually see it because it has a distal shadowing. So what happens is that with CT, I like it when I have a foreign body fistula, because I can see all the path of the foreign body, and I can tell the client, yes, it's in the subcutaneous tissue, but it's also in the iliopsoas muscle, and it came from the diaphragm, because I can see the lesion in the lungs. And this is something that I cannot do with ultrasound. But if I have a specific pocket where I suspect there could be a foreign body, I could just be able to see the reaction around it, but not the foreign body itself. And so I will tell the client, could you please check with ultrasound this point, because I think it could be there. And if it is vegetal, with ultrasound, you can pick it up. So that's why we advise ultrasound.
Makes total sense. I think that's it, Olga. Yep, I can't see any more. Just a final slide then, please, if you don't mind.
Sure.
We have one more of these webinars, the one you're doing next week, so on the 30th. If you would like to join Olga on that webinar, please just scan the QR code and it'll take you to the page where you can sign up. The QR code will also take you to a page which lists all of our other previous webinars, and you can watch all of them on repeat to your heart's content. Finally, if you'd like to find out how Olga and the rest of the team can support you and your practice with our high quality radiology reports, please just do drop our team an email. The email address is there, sales@VET.CT.com. They're incredibly friendly, and there's no obligation. You can find out as much as you like without any obligation. We're all here to help you. Thank you again, Olga.
Thank you. Thank you, Jemima.
Night, everyone.
Bye.